Hello, everyone. I'm Barb Gripshover, the medical director of the Special Immunology Unit, which is our HIV clinic here at University Hospitals. And I'm happy to be talking to you today about HIV criminalization laws in Ohio. I'm going to talk about how we got here and then why they need to change. So we're going to start first with the history, how these laws developed. So as most in this audience know, the HIV epidemic was actually first recognized 40 years ago this year. So it was 40 years in June that the initial report of 5 gay men with pneumocystis pneumonia in Los Angeles was reported in the MNWR. And then this was quickly followed by reports of Kaposi sarcoma and pneumocystis in men in New York and San Francisco as well. By the end of 1981, they had found also a cellular immunodeficiency reported in a cluster of men who had sex with men and persons who injected drugs in New York City, who also had pneumocystis. And then by the end of 1981, there were already 270 reports of severe immunodeficiency among gay men in the United States, and 121 had died. By 1982, the CDC actually came up with the definition of AIDS. And they defined it as a disease at least moderately predictive of a defect in cell-mediated immunity occurring in a person with known cause for decreased resistance to that disease, such as KS, pneumocystis, and other serious opportunistic infections. And already by September of 1982, there were almost 600 cases of AIDS reported, and 243 people had died, so 41%. So this was a pretty scary time. By 1983, the CDC and the Public Health Service put out recommendations for prevention of HIV. By that time, they had realized that AIDS had been reported in men who had sex with men, persons who inject drugs, women who had sex with men with AIDS, recipients of blood products, Haitians, and infants of mothers with AIDS, and that all suggested that it was a causative agent transmissible by sex and blood, similar to hepatitis B. And they also noted that there was a 60% case fatality at 1 year. Importantly, they did note that no person-to-person transmission had been identified other than through intimate contact or blood transfusion. And so they did put out some recommendations that sexual contact should be avoided with persons with known or suspected AIDS, and persons with multiple sexual partners increase the probability of developing AIDS. As a temporary measure, members of groups at increased risk for AIDS should refrain from donating blood, plasma or blood. So also in 1983, though, the researchers in France, Dr. Barthénussi and Dr. Montagnier, had identified the T-cell lymphotropic virus, retrovirus from lymph nodes of an AIDS patient, which we later was named HIV. And by 1985, we actually had the first commercially available test available for HIV approved by the FDA. And so then blood banks were able to initiate screening of blood products in the United States. But unfortunately, as we all know, the AIDS incidence and deaths continue to climb, so that by 1989, over 100,000 persons diagnosed with AIDS were diagnosed with AIDS, and 89,000 of them had already died. And as you can see in this graph from the CDC, this is causes of death from persons aged 25 to 44. And you can see starting from 1987, HIV moves to the top. And thankfully now we can say it's moved back down. And then in 1987, actually, this was the first AIDS quilt display in Washington. So also during that time, and The Band Played On by Randy Shilts was actually a best-selling book that chronicled the early HIV epidemic. And his intent was really to highlight the slow government response. And for those who've read the book or seen the movie, he followed the stories of different persons who were living with HIV, and also doctors that were taking care of them, and scientists at the CDC that were working to try to figure out the cause. But included in this book, he featured the story of a Canadian flight attendant who actually was initially part of a CDC AIDS cluster study in Los Angeles. And so this flight attendant volunteered to work with the CDC so they could help figure out transmissibility, actually, of what then they were calling AIDS. So this flight attendant had developed lymphadenopathy in 1979, and then KS in 1980. And then he was initially labeled in the, down here it's a reference, the CDC study as patient O for outside of California. But this got transformed to patient 0, suggesting that he was the original infection, which was never their intent. So in the CDC study, he reported, though, that he'd had 250 sexual encounters annually from 1979 to 1981, and he was linked to partners who had AIDS in both New York and LA. Then Schultz was an investigative reporter, so he was actually able to go and identify him by interviewing past partners, and this flight attendant sadly died in 1984. But Schultz in the book reported that patient 0 did not believe cancer could be contagious and therefore did not follow the advice of his physicians or the public health authorities and continued to have sex in bathhouses. And this got huge play in the media, as you can see even over here, and 60 Minutes featuring this patient 0 in 1987. Now, in fairness to this patient, he was not the source of HIV in the United States. So genetic studies actually show that HIV first arrived in the United States around 1971 from New York City in a strain very similar genetically to one from Haiti. And then it spread from New York City to San Francisco in 1976. And patient O/0 strain was similar to one that was in New York City before he ever had arrived there in 1974. So he was not the source. However, all this media attention was going on at the time that President Reagan decided to finally establish a commission on the HIV epidemic. So in 1987, Reagan set an executive order to create an advisory commission to, quote unquote, investigate the spread of the HIV and the resultant AIDS in the United States. And again, quoting from the actual executive order, the primary focus of this commission is to recommend measures that the federal, state, and local officials can take to 1, protect the public from contracting HIV, 2, assist in finding a cure for AIDS, and 3, care for those who already have the disease. The report that was generated in 1988 did actually recommend expanded HIV education and confidential HIV testing, the protection of legal rights for people living with HIV against discrimination by including as a disability, and also the expansion of care services to fill in gaps in the medical care system, which did lead to the future Ryan White program. However, it also had a special section titled Criminalization of HIV Transmission Recommendation. So they recommended that the states adopt a criminal statute directed to those HIV-infected individuals who know their status and engage in behaviors which they know are, according to scientific research, likely to result in transmission of HIV. And that they should impose on HIV individuals who know of their status specific affirmative duties to disclose their condition to sexual partners, to obtain their partner's knowing consent, and to use precautions. So this is sort of the first place they really talk about HIV disclosure laws. So in 1990, we had the passage of the first Ryan White Care Act. I think most everyone in this audience knows how important the Ryan White Care Act has been in providing care for people with HIV in our community and state and nationally as well. But the Ryan White Care Act was established as a multi-part program to fund metropolitan areas heavily impacted by HIV, states also, and individual community-based programs to provide HIV primary care, medications, and support services to low-income persons with HIV. It was named in honor of Ryan White, who's over here with his mom and sister, a hemophiliac with HIV who actually had to fight to attend school, who had died actually a few months before the law was passed at the age of 18. It has been renewed and revised in 1996, 2000, and 2006, most recently as the Ryan White HIV/AIDS Treatment Modernization Act, and now provides care to more than half of the people living with HIV in the United States, which is over 500,000 individuals with $2.4 billion in funding in 2020. So a super important act. However, in the initial, included in the text of the initial Ryan White Care Act, was the requirement of the state law protection against intentional transmission. So that it said that the secretary cannot make a grant under the Ryan White Care Act to states that unless they would show that their criminal laws of the state are adequate to prosecute any HIV infected individual who makes a donation of blood, semen, or breast milk and intends through such donation to expose another to HIV, engages in sexual activity if the individual knows that he or she is infected with HIV, and through such activity to expose another person, knows that he or she intends to infect someone through needles. And then they included the consent. It does not apply if the individual subjected to the behavior involved knows the other individual is infected and provides a prior informed consent to the activity. And also importantly, it actually did not require the states to have a specific HIV law as long as their general criminal law could be applied for this conduct. Now, I want to make an important note that this provision was completely removed during the 2000 Ryan White reauthorization. So this is no longer at all a part of the Ryan White Care Act, but that's what happened in 1990. So as a result, many states, they needed the funding. They started implementing HIV criminal laws. So you can see this is a time course back to 1986. Ohio first shows up here in 1988. I'm going to talk a little more specifically about Ohio. So you can see a lot coming here in the 88 to 1990, and then there's another little flurry here, 97, 98, 99, which I'll talk about a little bit more in a minute about states passing laws. So how about the Ohio laws? So the first law in Ohio was in 1988, which said that donating or selling blood, plasma, or blood products while living with HIV is a fourth-degree felony. In 1996, they passed laws against prostitution, solicitation, and loitering with the intent of solicitation, adding enhanced sentences if the offender was a person living with HIV. We'll talk about these more in a minute. 1997, they added that harassment of peace or corrections officers with feces, saliva, urine, or other bodily fluids would have an enhanced sentence if it was done by someone living with HIV. And then 1999 was the passage that probably aren't the most egregious of our laws, that sex without disclosure of HIV status prior is a felonious assault. And this law was really developed in response to another highly publicized media report in 1997 of a man in Western New York who had sex with multiple women and teenage girls after having tested positive for HIV, and 13 young women subsequently tested positive as well. So this led to laws in many states where you saw that little flurry of laws in the late 1990s and early 2000s. Even though this particular man was convicted on felony reckless endangerment in New York, a state which still actually does not have HIV-specific criminal laws. So these laws were made in a different time, and they really lagged the science. So we now know HIV no longer leads to an inexorable deadly disease. Rather, with appropriate care, is a manageable chronic illness with a near normal life expectancy. Yet the law criminalizes potential exposure to HIV with felony penalties comparable to assault with a deadly weapon based on pre-antiretroviral therapy outcomes. Furthermore, the law penalizes as potential exposures behavior that has essentially no risk of transmitting HIV. These laws were created in response to sensationalized media anecdotes when data shows that most people with HIV take measures to protect their partners once they know their status. And there's a really nice reference of reviews of that. So this is data from a CDC review, the estimated per act of acquiring HIV from an infected source. And I think the most important things to note here on this slide, first of all, these are people who are doing no protection, so no condom use, no male circumcision, antiretroviral treatment, or pre-exposure prophylaxis. We can see that biting, spitting, throwing body fluids, and sharing sex toys has really a negligible risk, and receptive and sort of oral intercourse is so low that you can't really measure. And even the highest risk, receptive anal intercourse, is only 1.4 per 100 exposures. So again, I think that hopefully everyone in this audience knows that we now also know that people who are on antiretroviral therapy for their HIV keeps them healthy and they live a long life, but it also prevents HIV transmission. So this was first shown in a really beautiful international study of nearly 1,800 serodiscordant couples who had been followed for over 4,000 patient years, where the positive partner was treated with antiretrovirals, and they looked for transmission to their HIV negative partner. And during this study, there were no linked HIV transmissions if the HIV partner's viral load was undetectable in antiretroviral therapy. There were 8 linked transmissions total. 4 were before the HIV person was undetectable, and 4 were in people that had come off their medicine or had developed resistance, but no linked transmissions if the partner's viral load was undetectable. This was followed by a large partner European cohort study that found the same, and therefore undetectable is untransmittable, which has been endorsed by the CDC in 2017. So, and the CDC's exact words are, people who take antiretroviral therapy daily as prescribed and achieve and maintain an undetectable viral load have effectively no risk of sexually transmitting the virus to an HIV negative partner. Therefore, an HIV infected person cannot transmit HIV to another or intend to transmit HIV to another by biting, spitting, or throwing bodily fluids, as we already said, that doesn't transmit, or engaging in sexual contact while on antiretroviral therapies with viral suppression. So an undetectable HIV RNA less than 200 copies per ml. Also, use of barrier protection condoms greatly decreases the risk of transmission in the absence of viral suppression. But even the riskiest sexual exposure, receptive anal intercourse, results in HIV transmission in only 1.4% of the time with no antiretroviral therapy or condoms. So the risk is low. So what exactly is the law in Ohio? So the Felonious Assault Law is probably the most severe of the HIV criminalization laws in Ohio. And that basically says that if you know you're HIV positive and engage in sexual conduct without disclosing your status, it's a second-degree felony, which is a minimum of 2 years. 2 to 8 years is the sentence for a second-degree felony. And unfortunately, the law does not currently account for any protection. So if you use condoms, if you're undetectable on antiretroviral therapy, none of those measures matter. All it means is you had sex without disclosing. Other laws we have, so we have laws that for prostitution or solicitation while living with HIV, it's a third-degree felony. But if you don't have HIV and do the same thing, it's just a third-degree misdemeanor. Loitering to engage in solicitation while living with HIV is a fifth-degree felony, but it's a third-degree misdemeanor without HIV. And I would just like to point out, there is no transmission in loitering, right? There's no even risk of transmission in loitering. And then finally, harassment with a bile substance. So this is causing another person to come in contact with blood, semen, urine, or feces, is a third-degree felony for people living with HIV, but a fifth-degree felony without. Again, we said you cannot transmit at all with that behavior. And then finally, selling, donating blood or plasma or blood products is a fourth-degree felony for people with HIV, even though we now screen for it. Whoops. So just to give a feel for us non-legal folks, what other kinds of crimes are punished at the same level? So other second-degree felonies, so comparable to the Felonious Assault Law for people with HIV, for non-sexual disclosure of HIV, sexual battery when the victim is under 13, abduction, aggravated vehicular manslaughter, all are second-degree felonies as well. So does not seem to be quite equal. Third-degree felonies, so this is the prostitution or solicitation with HIV or harassment with a bile substance. This is how reckless homicide, extortion, and child endangerment are all third-degree felonies. So, and then finally, fifth-degree felonies, which is what they're charged for loitering. Another thing is assaulting a school teacher. So they're definitely linked with more serious offenses. Now, these laws were created with the intent of protecting the general public. But we have to say there is no scientific evidence whatsoever to show that HIV criminal laws decrease new HIV infections or alter sexual behavior, including disclosure. So I'd just like to point out that states that have HIV criminal laws do not have lower rates of HIV or AIDS diagnosis than those who do not have HIV criminal laws when they compare using the CDC surveillance data. which is down here, Sweeney did that. Also, in surveys of people with or at increased risk of HIV infection, so men who have sex with men and people who inject drugs, they report no change in sexual behavior regardless of the presence of a law mandating disclosure or safer sex in their state. So actually, most people believe it is wrong to expose others to HIV, and disclosure is the right thing to do regardless of the law. And then in another study that I think is interesting that was done in New Jersey that does have an HIV disclosure law, the people that live there reported the same rate of disclosure regardless of their knowledge of the existence of a law. So they interviewed 479 people in New Jersey, and half of them did not know about the law and half did, but 84% in each group still had always disclosed their HIV status to sexual partners or were abstinent in the prior year. So they don't do their main thing in terms of helping to protect other people, but in addition, they also cause harm. So these laws perpetuate HIV stigma, which is a main barrier to engaging patients in care. We know that HIV stigma is associated with depression and poor medication adherence. Poor medication adherence leads to poor viral suppression, and if we don't have viral suppression, that can lead to that ongoing transmission. These laws may also discourage people from getting an HIV test, as you can only be prosecuted under this law if you know you have HIV. So if you don't have a positive test, they can't prosecute you, even if you would share HIV with someone else. And then finally, I thought this was a very interesting study. They looked at the rate of HIV tests in states that had media reports of HIV criminalization laws, whether either someone was prosecuted under the law or they were developing new HIV criminal laws. And when they had increased media reports of HIV criminalization, there was actually a decrease in the amount of people testing for HIV in the next year. So again, adverse effects of media. Also, our HIV criminalization laws further health disparities. So as everyone knows, I think, in this group, HIV disproportionately burdens communities of color, but persons of color are also more likely to be prosecuted under these laws. In California, 2/3 of the people who were arrested for HIV-specific crimes were Black and Hispanic, while they comprise only 50% of people living with HIV in the state. The CDC actually and the US Department of Justice endorsed modernization of HIV criminalization laws. The CDC in their End the Epidemic plan states, when a law meant to protect the public is not working as intended, is unjust, and may be hurting efforts to keep communities healthy, common solutions must be found to better meet public health and public safety goals. And the US Department of Justice in their Civil Rights Division in 2004 released a best practices guide to reform HIV-specific criminal laws to align with scientifically supported facts, which was to advise states on modernization. We're trying to fix some of the bad federal guidelines in the early end of the epidemic. And then since 2014, 5 states have modernized some of their HIV laws, including California, Colorado, Iowa, North Carolina, and Michigan. So how about in Ohio? So in Ohio, we have an Ohio Health Modernization Movement, which is a statewide coalition that's working to get Ohio's HIV laws changed. Anyone can join, and I hope that everyone will join. I have the link down, ohmodernizenow.org, where you can sign on to join the movement. They have monthly meetings going on, and they have subcommittees. We have a legislative subcommittee that's working on, has actually drafted the changes of the law. They have monthly webinars as well, educational webinars as well. But the draft law that we are hoping, the bill that we're hoping to get submitted and passed in this legislative session will clean up use of stigmatizing language regarding HIV. It will eliminate all HIV-specific felony laws, including felonious assault for failure to disclose HIV status, as well as HIV-specific accelerated penalties for prostitution, solicitation, loitering, and harassment by throwing bodily fluids. It will create a new law prohibiting intentional transmission of HIV, for persons who do all of the following: fail to disclose status, engage in conduct that possesses a substantial risk for HIV transmission, fail to take means to prevent transmission, and actually transmitting HIV to the other person. And this would be a first-degree misdemeanor. And it expunges all convictions based on prior felony laws. Again, they're hoping to get this bill in this legislature. They're still looking, I think, for Republican co-sponsor. But everyone can join the movement. So please go to the website and sign on. So in summary, people with HIV now have a life expectancy near that of persons without HIV, but our current criminalized behaviors with little to no risk of HIV transmission, and as such are unjust. These laws have not been shown to promote less risky behaviors or decrease HIV infections. They do, however, perpetuate HIV stigma and further health disparities. And importantly, these laws impede our public health goal of getting all HIV infected persons diagnosed, in care, on meds to stay healthy, and HIV. Thank you.